thank you once again for joining the August meeting of the Nigerian Society for Colorectal Disorders. Today we have a special guest in our midst, Dr. Hammed Ninalowo. He is an interventional radiologist of both national and international repute, and he has gladly agreed to give us a rundown on the role of interventional radiology in colorectal surgery. So we're very grateful to have him in our midst. We will soon be handing over the floor to him to start his presentation. At the end, Mr. Augustine Eguare, our international rapporteur, and a member of our Best Board trustees, will conduct the Q&A session. Please send in your messages via chat, and of course, there'll be room for a verbal Q&A at the end of the meeting. And without further ado, I'll hand over the platform to Dr. Hammed Ninalowo to continue his presentation. Thank you.
Hello, good evening, everyone. Thanks for inviting me to speak with your colleagues this evening. I'm trying to share my slides. So let me just see what's happening. There's something happening. Okay, can you see my screen? Dr.
Yes,
you can see my screen?
Yes, we can.
All right, so thank you everyone for having me this evening. My name is Dr. Hammed Ninalowo. I'm a vascular and interventional radiologist. I primarily practice now in Lagos. I still a little bit in the US, but most of my practice is in Lagos. I've treated patients with quite a few of you already, so it's a pleasure speaking with you this evening. So I'm going to talk about our role in the management of patients with colon cancer, typically, which is usually in the management of patients who have metastatic disease from colon cancer. As we know, colon cancer is one of the most common cancers in the world, the third most common cancer in the world, and you know one of the prevalent causes of death globally. About 20 to 25% of patients who present with colon cancer at the time of diagnosis also present with metastatic disease, and the ones who do not present with metastatic disease at the time of diagnosis, about 50 to 60% of them will have metastatic disease in the course of their disease, which is where we play most of our role. As you know, interventional radiology plays a key role in the management of oncologic patients. We actually have a fourth pillar of oncology now called interventional oncology, where we do a lot of work with cancer patients, a lot of work with patients with hepatocellular carcinoma, biliary malignancies, and then metastatic disease from other cancers. And we can play an essential role in both the diagnosis of these cancers and also the subsequent treatment of these patients in diagnosing the primary tumor, doing things like biopsies in diagnosing them when they have metastatic disease, also treating perioperative complications for patients who have surgery, also treating patients who have obstructive symptoms in colon cancer. And then we also play an adjunctive therapy to surgery in most of the cases. And also we do primary treatment for metastatic disease. So I'll just go through this and what our role is in colon cancer. As you know, most patients with colon cancer are now diagnosed basically with colonoscopy. And that's the primary role of that. That's the primary mode of diagnosis for most patients. However, we still have this subset of patients who have these lesions that are submucosal or subserosal that are very obvious on a CT scan, such as this patient. As you could see on here, this patient has very thickened wall. This patient has colorectal lymphoma. This is a lesion that's quite easy to biopsy using an ultrasound to get a needle into this region without the patient having to go through a colonoscopy, and doing this with just a local numbing medicine to get a diagnosis from this. But as you know, most patients do not present in this manner. Most patients presents with submucosal lesions that are biopsied usually with colonoscopy. So we don't play a large role in the diagnosis of primary colon cancer, but we do play a large role in diagnosis of metastatic disease. So such as this is a patient with a lesion in segment 8 of the liver that was discovered after they knew that the patient had colon cancer. And this is a patient with multiple lesions in the lung. And we can do image-guided biopsies for these patients. This is an example of a patient with a tumor in segment 6 of the liver going to segment 4B. And we know that this is a lesion that is very accessible with ultrasound. As you can see, we have a needle basically coming into this lesion to get a sample of this lesion to make a primary diagnosis there. For lesions that we cannot see or identify well with ultrasound, although this lesion, if we were to look at it properly with ultrasound, we should be able to find this lesion with ultrasound, but this lesion was biopsied with CT guidance. So basically lesions that cannot be biopsied with ultrasound, we can also get them with CT guidance. And this is an example of a CT guided biopsy targeting this lesion directly on CT and getting a needle into that lesion to get a histologic diagnosis. For patients who have perforated colon cancers or patients who have undergone surgery and have fluid collections post-surgery, usually abscesses, we could definitely do image-guided drainage for those patients also. Again, this is one such example of a patient who had a rectal resection with a Hartmann's pouch. And you could see that there's a pre-sacral collection here that was an abscess. And instead of this patient going back to surgery for re-exploration, we can place a CT-guided drain, basically hogging the sacral bone there, which is the avascular zone in this patient, and putting a drain in essentially to resolve that abscess without going back to surgery. We've also had instances even here in Lagos of patients who have colon cancers and have had torrential gastrointestinal bleeding with colon cancers that we've had to do embolization for. And we also play that role in being able to stop bleeding in these patients that are already quite sick, and some of them may be poor surgical candidates and do not need to go through a bowel resection. When these patients are bleeding, we could do a CT scan such as this, where we do a protocol where we see in the angiographic phase, in the arterial phase, we see extravasation of blood there. And this is a lesion we can get to. We know that this is coming from the inferior mesenteric artery. And with a tiny catheter in the groin, we could find a way to get a microcatheter all the way out to the bleeding point and then put in coils in that vascular territory to stop bleeding. So that's another role we could play in these patients. We used to do quite a few of these where we would place colonic stents, but it looks like our GI colleagues and our surgeons have basically advanced in their skills with endoscopy and fluoroscopy, and most of the stents are placed now by endoscopists. But in lesions that are still very tight, we could still play quite a bit of a role in basically either assisting the surgeon or working collaboratively with the surgeon to get a wire past a very tight lesion, a hydrophilic wire past a very tight lesion to do a dilation, basically dilating a stricture and then placing a stent in those patients. So we could still, obviously, we're not the primary service that places the stents anymore. However, we could still play an adjunctive role in these patients when needed. Now, so we do a lot of local regional therapies in patients with colorectal cancer, and these local regional therapies could be done either to improve surgical candidacy. It could be therapies with curative intent, and we'll talk about that a little bit. And then we also do therapies with palliative intent, but we'll start with basically the therapies that we provide to improve surgical candidacy. As you know, a lot of patients with colon cancer develop hepatic metastasis. However, especially when a patient has a large tumor within the lobe and they need a hepatectomy, a partial hepatectomy, a right or a left hepatectomy, you need a functional liver remnant that's a certain percentage. So if a person has a normal liver, you typically need about a 20% functional liver remnant. If the person has been exposed to chemotherapy, as most patients with colon cancer have, you need at least a 30% liver remnant. And then if the liver is cirrhotic, you need at least a 40% liver remnant. However, if you do not have that liver remnant, you typically cannot take that patient to a partial hepatectomy. And this is where we come in. We could do something called a portal vein embolization, which is a procedure which we're doing, basically diverting flow away from the lobe where the tumor is and basically diverting flow towards the healthy lobe, such as this case. So this is a patient with a tumor in the right hepatic lobe where we've gone in transhepatic into the portal vein and basically embolized the portal vein on that side of the liver. And what happens is you get hypertrophy of the non-embolized liver in those patients. So this is basically an intraprocedure picture where we've basically gone in transhepatic, gone into the portal vein with a catheter here. And you can see a portal venogram here showing the branches of the left and the right hepatic lobe. And in this case, the tumor is somewhere here. The goal here is basically to embolize all of the branches of the right hepatic lobe and leave the left hepatic portal vein branches patent. And as you can see, post-procedure, you can see basically this is where the right portal vein branches would be. Those do not opacify anymore post-procedure, or you could see opacifying at this time is the left hepatic lobe, left hepatic portal vein branches. You could see a few weeks later, when you get a CT scan, you could see that the left hepatic lobe here only measures about 56 millimeters in transverse dimension. However, it's gone up significantly post-embolization. So you've gone through hypertrophy with the left hepatic lobe, and now you could do a right hepatectomy quite safely. So PVE has become the standard of practice in patients with inadequate FLR prior to extensive hepatic resections. And we expect the liver to regenerate about 20 to 46% in about 6 to 8 weeks in these patients. Resection about after PVE is reported to be about 60 to 80%. 20% of patients may still have insufficient FLR, even when we do what's it called, portal vein embolization, or may have tumor regression. Tumor progression post PVE while you're waiting for that liver to get to a certain size. Another adjunctive therapy that we've looked at basically to cause a hypertrophy in the liver is something called transarterial radioembolization, also called CERT. And basically, this is basically radiation. So what we're used to, especially in this environment, is external beam radiation that exposes the normal hepatic parenchyma to radiation in addition to the target tumor. The advantage of doing transarterial radioembolization is basically getting the radiation therapy specifically into that tumor bed, into that area where you want it, and basically that doesn't spread significantly to the normal liver. So these are basically glass or resin loaded with yttrium-90 that's injected into the hepatic arterial vasculature that's around tumor or within the tumor, and this emits beta radiation, which only travels about 2.5 millimeters from the target zone and really doesn't spread to the normal liver if you could get it to the right location. But we've looked at quite a few studies in interventional radiology looking at the difference between doing PVE and TEER. And we've seen that PVE is just better. Portal vein embolization has been shown to have much greater FLR improvement than transarterial radioembolization. And especially in an environment like ours, where we know that transarterial embolization, radioembolization is significantly expensive, and the logistics to do this is also significantly difficult. I think PVE is much more achievable in our environment. The only advantage that's been shown with transarterial embolization is that you get tumor control, because you're not only basically stopping blood flow to that tumor, you're also basically killing tumor at the same time. And the other advantage is that you're giving time to actually look at the biology of the disease. Basically, if you were to do a transarterial radioembolization, you have to wait a significant amount of time before you go to do hepatic resection. What you're doing at that time is you're basically looking to see if there's tumor progression anywhere else in the liver or tumor progression anywhere else in the body that basically now negates the fact that you're going to go do hepatic resection in the first place. There are some side effects that have been shown from transarterial radioembolization, such as pain and nausea. We've also shown some mild worsening of the liver function in patients while we're waiting for that FLR to get better. We've also seen some serious toxicities, including irreversible ascites, temporary or progressive hyperbilirubinemia, or variceal hemorrhage, which may be observed in these patients. And we know that this happens because we know that when you do transarterial radioembolization, it affects the liver to an extent where you get a bit of portal hypertension, and these patients could develop variceal hemorrhage or splenomegaly. We also have adjunctive therapies, typically with ablation, though the ablation therapy that was common before was radiofrequency ablation. But we basically moved on from radiofrequency ablation now because it was quite clunky to do. Now we do something called microwave ablation, which is also available here in Nigeria. And what microwave ablation does is basically generates heat by utilizing electromagnetic signals. And this causes coagulation necrosis by the oxidation of polarized water molecules, which then produce friction and heat. So when you compare radiofrequency ablation to microwave ablation, with radiofrequency ablation, we needed to use multiple probes in order to kill a tumor. However, with microwave ablation, you pretty much need one probe. Basically, the size of the burn zone is basically proportional to the time of burn. And what we found with microwave ablation is that you also have less heat sink effects. And what heat sink effect is basically something that used to affect radiofrequency ablation quite a bit. Is basically, if there's blood flow in the region where a tumor is, the temperatures would not get high enough in that area, which means the tumor kill in that area is poor. We don't really see this with microwave ablation because it's much better technology, and we get much better thermal conductivity with microwave ablation. So the nice thing about microwave ablation is it's a minimally invasive procedure. You could pretty much do this with just a little bit of local numbing medicine and a little bit of sedation, and can be delivered as an outpatient treatment. So this is one such procedure. Basically, this is a lesion in the liver from a colorectal cancer metastasis. We brought in a probe from the skin using ultrasound targeting basically into the lesion, and basically you turn on the machine. And when you turn on the machine, what you see is basically this cloud that develops, and basically it's just tissue boiling. And this is basically there's a pre-MRI in this patient. This is the pro-MRI, post-MRI in this patient. And when you compare microwave ablation to surgical resection, you get much less tissue damage compared to surgical resection. And a lot of these patients, especially with patients with 1, 2, or 3 lesions, this is very good technology as long as we could get from the skin to the lesion without the patient having to go through surgery. As you know, some of these patients would also have lesions that are not visible by imaging. So the more we could avoid surgery in these patients with metastatic disease, the better it is for them. This is another lesion. This is actually a lesion, a hepatocellular carcinoma that we treated here in Lagos. This is the lesion before treatment, and this is during the treatment, basically, again, showing that cloud that develops from the hit that's formed within tissues and causes a lot of shadowing on the ultrasound when we turn on the machine. We've also looked at a lot of studies in interventional radiology with first-line chemotherapy plus transarterial radioembolization, and there were three big phase 3 clinical trials that were done for this: the Surflux trial, the Foxfire, and the Foxfire Global, which studied the efficacy of combined chemotherapy with Y90 transarterial radioembolization over just chemotherapy alone in over 1,000 patients. And basically, with the Surflux trial, basically there was an addition of TARE to chemotherapy or chemotherapy alone. And basically, the gist is that the addition of TARE to chemotherapy did not improve progression-free survival, however, it delayed tumor progression significantly in these patients. When you look at this paper by Wesson et al. In 2017, where they looked at they basically showed basically comparing again single therapy versus combination therapy. You see that there's a higher overall response rate reported in the combined group, which was 72% versus 63%. Again, however, there was no difference in the overall median overall survival of 22.6 months versus 23.3 months. When you look at the radiologic progression of the tumor, you could see that, again, it's better in the combination group, 31% versus 49%. The cumulative incidence of tumor progression in the first 12 months was, again, better in the combined group, 22% versus 39%. An objective response rate was also better in the combined group, 72% versus 63%. And then, but again, there was a higher odds of having an adverse effect in the combined group, which is expected because they're getting combined therapy versus a single therapy alone. When you do the combined analysis of the Foxfire, the Surflux trial, and the Foxfire Global trial in over 1,000 patients, again, the important thing to note is that there is no significant difference in overall survival between the combined group versus the FOLFOX group, and this was quite disappointing for us in interventional radiology because we were waiting for the results of this trial for a long time, and we thought it would be good. However, when they stratified the patients based on tumor location, they showed that in addition to SIR, the addition of SIR did improve overall survival in patients with right-sided tumors, but not left-sided primary colorectal cancers. So TARE has a significant impact on overall survival in patients who have right-sided tumors, 22 months versus 17 months, but not left-sided primary tumors. Again, I caution you to really not think about TARE a lot in this environment because, again, this is very, very expensive therapy, and it is very difficult to get all the coordination to get it done here in Nigeria. So this is not something we've invested in. However, we do something called transarterial chemoembolization in Nigeria. Typically, we use something called conventional TACE. We typically do this mostly in patients with hepatocellular carcinoma. However, we've also applied this in some patients with neuroendocrine metastatic tumors or a few patients with colorectal cancers. But again, not a lot of good results from TACE, which is why TARE is mostly used, especially in the palliative setting, which we'll talk about. When you talk about conventional TACE in HCC, we typically use doxorubicin as our chemotherapeutic agent now. And in colon cancer, we typically use irinotecan. And with conventional TACE, what we're doing is we're mixing the chemotherapy agent with an emulsion oil called lepiodol. And lepiodol is an oil which we also call it liquid gold because it's so expensive. And basically, when you mix the oil with the chemotherapeutic agent, it gives you more of a stable emulsion. It gives you slower drug elution when you inject it into a patient, lower plasma concentration also, because it basically stays in the liver where you left it, and higher tissue concentration. We also have DEB-TACE. Again, this is something that was created by the pharmaceutical companies as a better alternative to conventional TACE, but we've not really seen a significant difference in the West as far as the difference between conventional and DEP TACE. Even in America, I still use mostly conventional TACE. I almost never use DEP TACE, but some of my partners are very big believers in DEP TACE. And the bottom line with DEP TACE is that they're basically soaking the chemotherapy in beads overnight, and basically the beads hold onto the chemotherapeutic agent, and then you really don't need LIPI at all for the procedure. So you're essentially injecting the beads by themselves, which are already loaded with chemotherapeutic agents. And we've seen some studies basically doing the Biri TACE, which is irinotecan laced beads. And we did show some improved overall response rate versus doing nothing alone, or chemotherapy alone, or I'm sorry, versus FOLFOX and bevacizumab. Sorry with my pronunciation. But again, this is not something we really use anymore as far as TACE in colon cancer. We typically use transarterial radioembolization even in the salvage setting. So we do have guidelines that still support using transarterial radioembolization as a treatment option in patients with colorectal cancer metastasis, especially who are refractory to over 2 lines of systemic chemotherapy. And there is a category 2A and a grade B recommendation as part of the European Society for Medical Oncology and National Comprehensive Cancer Network for this. We've shown that the overall survival of these patients, especially when they are not responding to over 2 systemic chemotherapeutic agents, is quite good, up to 9.6 months in some studies and 10.6 months in some studies. So we could still use transarterial radioembolization as a salvage in these situations when patients are not responding to systemic chemotherapy. So basically, with the gist with transarterial radioembolization, basically the gist is essentially in the primary setting, there is no benefit as far as overall survival when we combine CERT, which is transarterial radioembolization, with chemotherapy. However, in patients specifically that have right-sided tumors, we have shown a benefit in overall survival. And in patients who need salvage therapy, we've shown that if a patient is not responding to over 2 chemotherapeutic agents, then they could benefit from salvage therapy with TARE. As far as future directions, the combination of immunotherapy and targeted ablation is a new revolutionizing concept based on enhanced exposure of the tumor tumor antigen. And basically, the concept behind this is that the ablated and dead tumor cells release tumor antigens into the bloodstream, which then augments T-cell response, enhancing the efficacy of the immunotherapy. And both the pro-inflammatory cytokines, such as interleukin-6, and anti-inflammatory cytokines, such as interleukin-10, get elevated in these patients after ablation, the ablation procedure, and then enhances the tumor response in these patients. But again, all in all, conclusions for metastatic disease: in case of unresectable tumors or non-surgical candidates, evaluation for ablation is recommended if we can get the tumor in these patients. As far as targeted therapies, we look original therapies. We've shown that, again, we don't really have good overall survival in patients, better overall survival versus chemotherapy alone when we use CERT, but patients that have right-sided tumors can benefit from CERT if they're treated as a primary treatment algorithm. TACE and TARE, conventional TACE and DEP TACE is considered with patients is only considered now in patients who have progressive disease after Y90 TARE has failed in this patient, again, only as salvage therapy. So basically what we do now is we give most patients systemic chemotherapy, just like you're doing already. If the patients fail systemic chemotherapy, we can do TARE on those patients. If they fail TARE, then they can move on to TACE, essentially, as salvage therapy. Thank you very much, and that's my talk.
Thank you, Dr. Ninalowo, for this erudite and very enlightening presentation. I'm sure we would have a number of questions and comments regarding this, but I'll turn over the next stage of the event to our international rapporteur, Dr. Emmanuel Barry. Over to you, sir.
Yeah, thank you so much, Dr. Ninalowo. That's an excellent presentation, very educative, very informative. Thank you so much. and I think it's so up to date. Thank you, thank you, thank you. I think I will encourage us to put our questions on the chat site, and if there are people that want to ask questions, you can also just indicate by raising your hand. Okay, Dr. Ahmad, I can see your hand up there. And so we'll start with question from Dr. Mukhtar Ahmed.
Hi, yes, thank you. Thanks for acknowledging me. Many thanks for the fantastic presentation. I thought it was a tour de force in the role of IR in colorectal surgery. Certainly, you've brought a fresh breath of air, to with your involvement back in Nigeria, which I've followed keenly, which is something that we've needed for a long time, because interventional radiology is expensive and very difficult to set up. My question is about MDTs. So some of the work that we have been doing together with partners like Shagun Komolafe and others, and Akuya Sombang in our group, is to try to embed MDT practice. And what has been your experience was what I was going to ask you about the interface. How have you found the working relationships between the different specialties? Because you've described certainly lots of IR is what brings a lot of what we do together. There's the treatment of metastatic disease, there's treatment of locally advanced primaries, which is the majority of presentations in Nigeria, and the growing role of gastroenterologists extending their scope to doing more interventions than has been traditional in Nigeria. So what has been your experience of the role of MDTs, or how much MDT discussion has been involved in sort of the cases that you found, and how do you think we can improve that? Thank you.
So interesting. So I think for us, so we also have a teleradiology company called Accurate. And because of that, we service two cancer centers in Lagos, Lakeshore Cancer Center and Master Road Cancer Center. So one of our radiologists typically staff, usually my partner, would typically staff that MDT basically every week. And we try to be present at that MDT. So we typically have surgeons, oncologists, radiologists, radiation oncologists, all on one MDT talking about each patient. So we have that quite very well established with the cancer centers in Lagos, obviously. As far as outside of Lagos, we are not involved in any MDTs, but I am constantly talking to one doctor or the other all over Nigeria, talking about one patient or the other. So we have these mini MDTs, but typically not traditional like we're used to. But for two cancer centers in Lagos, those are very well established, and we have them going already.
Okay, thank you. I have a question or two questions from Dr. Olassi. The first one says, what is the risk of upstaging a tumor following a transcutaneous biopsy, like the example shown for the right colon tumor?
Sure. So basically, I mean, we've really not seen a tumor seeding from the way we perform biopsies. So I noticed when I got to Nigeria, a lot of people do biopsies without trocar technique, which means they're just putting a biopsy gun in and biopsying things, right? So in interventional radiology, we typically use trocar technique where we're putting a needle in. So for example, if we're doing an 18-gauge biopsy, we would typically put in a 17-gauge trocar needle and go in and out through that same needle multiple times, right? And we still haven't seen any issues with seeding with that technique. So I know we've had a lot of questions, especially with hepatocellular carcinoma, as to, should we be biopsying a lot of these patients? And typically with hepatocellular carcinoma, we really don't want to biopsy those patients in the first place, because a lot of those tumors a diagnosis can be made with imaging. But when we do have to biopsy a tumor, we're not scared to do that if there is a question on imaging, because we know that we don't spread tumors in those situations.
Okay. Yeah, maybe just in line with that also, I was thinking, in fact, this is one curiosity I've always had. In terms of ablation, when you embolize, when you ablate either by ultrasound or microwave, almost the kind of visualization that comes to my mind is like shattering an asteroid, where you have these little pieces vaporizing. What if you have still your residual viable tumor cells? Could that lead to a propagation of the metastasis?
Yeah, so basically, when you're looking at it, so if I have a 2 centimeter lesion to ablate, I'm going to ablate at least a 3 centimeter zone.
Okay.
So there's usually a zone around the ablation, around the tumor that I'm definitely going to ablate, right? And then a lot of people also ask about seeding when we do ablation. So when we do ablation, we also ablate the tract. So basically, once we're done with the ablation, we leave the machine on and we come out ablating the liver tract as we're coming out of that lesion, right? And that basically kills any tumor cells on our needle and along the tract when we're coming out. So we typically do not see seeding because of that also. But I mean, obviously, when we are ablating, we are releasing antigens into the body. But what that's shown, what we've also shown, we're releasing these antigens into the body is basically that the tumor, the body's response to the tumor is usually better. The body's immune response to the tumor is usually better. So we're not causing it. We're not doing anything bad with that either.
Yeah. Thank you. And you were talking about the interleukin-6 and the interleukin-10, the pro-inflammatory and the anti-inflammatory. How do you strike a balance? Is this predetermined by the patient's biology? Which
No, I mean,
produce
we don't know the patient's
predominantly?
biology at all. We just ablate and hope for the best, really. We don't do any pre-workup or any immune testing on the patients. We just ablate.
Okay.
And we hope for the best.
Thank you. And then there's another question from Dr. Lassie. He says, is there a role for TAR as an alternative to other forms of neoadjuvant therapy for locally advanced colorectal cancer without distant mets?
Without distant mets, no, absolutely not. So we would only do tear in the liver. We would not go put in radiation particles in the colon because that would probably cause a lot of damage. So there's no role for tear in those settings.
Yeah. So to be clear, this is a hepatobiliary procedure, really.
Correct.
Metastasis outside the colon. Okay.
Correct.
Dr. Mukhtar, your hand is up. Do you have another comment or question?
No, it was a lazy hand, sorry.
Okay. All right. Okay, and there's a question there from Dr. Igwe. It says, how do you select, oh, please, it's Lipitor. I mean, that's the liquid gold you talked about. How is Lipitor, is it available easily in Nigeria? And how
No,
do
it's
you
not. So we have to, when I started my practice in Nigeria, we had to bring it in from America. It was much more expensive. But we now have a source in India to get it for about a third of the price.
Okay, and how do you select patients pre or post embolization before surgery?
So you mean for ablation?
Yeah, that's the question. So how do you select your patients pre or post embolization? It's not very clear before surgery.
Before
I guess what is saying is, how do you select which patients would benefit from embolization? Well,
okay.
Again,
so if you heard what I said in the talk,
yeah.
No,
maybe
what I said in the talk,
really
sorry.
Yeah, go ahead. There's delay. There's some delay.
So as far as tear, right? I am not a big believer in using tear as a pre-embolization tool before surgery. Right. Number one, it's super expensive. Number two, you have to wait a long time to get an improvement in the FLR. Right. So because of that, portal vein embolization is much more effective, much cheaper, and faster. Right. So we really don't do a lot of embolizations for patients before surgery in those settings. So portal vein embolization is typically what we would use in those settings. However, we still use tear typically as salvage therapy for patients who basically do not benefit from 2 lines of chemotherapy or are resistant to chemotherapy.
Okay. Thank you. And that brings me to the issue of access and cost. I know you said your MDT is mainly in Lagos currently.
Right.
How do patients access this therapy, and what is the cost implication?
Yeah, so I mean, as you know, I think Dr. Mukhtar said, first thing he said is interventional radiology is expensive, right? So we know that interventional radiology is expensive, but we have also shown that we can do interventional radiology much cheaper here in Nigeria than you could get it anywhere else in the world, right? But if you look at most of the centers we do interventional radiology in Nigeria right now, it's mostly private centers, not a lot of public institutions, right? So things are much more expensive in private centers than they are in public institutions. But we've done like ablation at Lutz before, right? We've done an ablation at the University of, I'm sorry, not at the University of Ibadan, only at Lutz, right? But the probe to do the ablation still costs the same. And I'll tell you the cost of the probe. For example, each ablation probe costs us $900 from the supplier in Nigeria to use. Right now, that's about 1.5 million naira. Right, an average patient cannot afford that, but we can't help that. That's what it costs from the supplier, right? And the supplier has put in the investment to bring it to Nigeria, and the only way for them to basically have a sustainable practice or a sustainable business is for them to be able to sell that product at that price. So we have to recognize that, right? So what have we done as a practice to make sure that interventional radiology continues to become cheaper and cheaper, right? Obviously, we can't subsidize care for cancer patients. That's not something we would do in our practice at all, right? But we've also done teaching. Like we had a fellow that graduated from our practice recently, did a fellowship with us, and now is back at the University of Ibadan. And if there were a patient that needed microwave ablation in Ibadan right now, he can do that, right? At a much lower cost to the patient than we can get in Lagos. So we're making small progress. It's much cheaper than it is in America and England already here. It's about a third of the price. Can we get it much cheaper? Yeah, if we could get it into the public institutions. But we also don't have the infrastructure in the public institutions to deliver things like transarterial chemoembolization, transarterial embolization in these patients. So they still have to come to the private institutions, unfortunately.
Yeah. I think the solution to cost is usually diversification. If more people practice it, then the sheer volume then will just help in terms of.
Well, I think there's going to be a lot of improvement in interventional radiology in Nigeria soon. I mean, a lot of people have gone out to train since I've been back, right? They've gone to train in places like Tanzania. They're coming back home now, and things like ablations and very, very straightforward procedures can be done today at most of the public institutions without a lot of resources. So that would already make things much cheaper.
Great, thank you. And there's this question from Dr. Babajide Olade, and he wants you to give accurate definitions of the following terms: operable tumors, unresectable tumors, inoperable tumors. Yeah.
Accurate definition of the following terms.
I mean, this definition, is it in terms of liver mets?
Are you talking about in terms of liver mets?
Colorectal tumors. That's because my understanding, if, for example, this was in regard to colorectal tumor, operable tumor means this is confined to the gut and you can resect it. It doesn't have any attachment to surrounding vessels and nerves and ureters and all that. So operable or resectable, I think, would be the term there. But unresectable means this distal metastasis or local spread with invasion of contiguous organs that will make it unresectable. Even when you take out the primary tumor, you're going to inevitably leave behind residual disease, which is really not beneficial to the patient. And then the inoperable, I guess, again, for those patients, the patients that have advanced disease, peritoneal disease. So some of these patients can be diagnosed preoperatively if you can identify the peritoneal disease. But at surgery, if patients have significant or mental disease, peritoneal disease, then it really makes it inoperable, because any attempt at, well, if the patient is obstructed, you could perform a palliative diversion just to palliate the patient, but by definition, that would be inoperable. I don't, your views will be welcome.
If I may just comment on that question,
Yeah.
although it's probably not directly related to the presentation, it's more of a general basic question for oncology. But even though the terms operability and resectability are used interchangeably, the strictest definition will depend on whether you're describing the patient's physiological status and in terms of ability to withstand the intended procedure, or whether the tumor itself can be taken out of the body without leaving out residual cells. So if we're talking about strict definition, operability refers to the patient's status. So if the patient is moribund, is hypoproteinemic, he has lots of comorbidities, it will be unsafe to take that patient to the operating theater. So the word inoperability comes in that line for that definition. But if the patient's tumor cannot be taken out safely without leaving behind residual cells or tissue, then that tumor becomes unresectable. But again, those are the stricter definition, but in terms of many people still tend to use them interchangeably. So, but again, like I said at the beginning, this probably is more of a general question rather than specific to this topic. Thank you.
Thanks, and Dr. Mukhtar Ahmed.
I just wanted to add to that, as Dr. Ade said, it is the terms that are used often interchangeably, and even at many established MDTs, it does cause some confusion using them interchangeably. And I think the important thing to clarify is to use the word currently inoperable. If you're saying somebody is inoperable, because you might give them immunotherapy and you get a complete response. You might give them chemotherapy and downstage them. You might use some of the therapies that our erudite speaker has described in a liver metastasis, which was previously unredeemed inoperable, and make it operable. So I think it is really important that we don't use it as a closing off word, because one of the problems is, and we see it even in the developed health economies, where sometimes when the word is used unresectable, then the impression is given that that's it, sort of for the patient, as the people take away that impression. And I think what is important is to describe the current situation, to say that this tumor is currently unresectable, but that doesn't mean it will never be resectable, and that you might give other adjunct therapies which might make it resectable. So I think it is important to use the context. I think in terms of Dr. Olada Babajide's question is in terms of the operable, unresectable, inoperable. As we've said, they are often used interchangeably, but the important thing is to clarify the context, that the situation could change. Thank you.
Great, thank you. And there's a question where I think Dr. Ahmad asked the question: is there a fellowship program for IR in Nigeria? I think Dr. Wada says he doesn't think so, but do we have any? I think you said you trained somebody from Ibadan's currently recently.
Thank you, sir. Mm-hmm.
Yeah, so we trained. Sorry, did you ask me that question?
Yes.
Oh yeah, so we trained Dr. Peter Adenigba. I think he's also on the call here from Ibadan. So he's a fellow. He was a fellow for 2 years, and now he's back in Ibadan, one doing IR. Still comes to Lagos to help us with some complex interventions.
Okay, so there's a fellowship kind of going on at your center in Lagos. So people
yes,
who
we started a fellowship in collaboration with RADAID International 2 years ago.
Right. And Dr. Adeyeye asked the question, what are the risk and preventative measures?
Sorry, sir. Can we go on the question on fellowships? I know that something was being done up north, I think in the Northeast, if I'm not mistaken. I think in Maiduguri. I don't know if...
Yeah, Professor Bakari wanted to say something.
Thank you.
Yes, good evening, bro. I think we have an interventional radiologist in Maiduguri. That is Professor Hammed Ninalowo. That is the current chief medical director of the institution. And he has done a couple of interventional radiologic techniques, especially that of fibroids, uterine fibroids. And I think I and him, we did some IR on patient who is having intra-abdominal bleeding, as the presenter said in his presentation. He also has done some embolization, that is hepatic metastasis embolization. He has done some. Even recently, he did one. A patient came from Lagos to see him in the teaching hospital. So I think if he is in the forum, I think he will have thrown more light on this thing. Thank you, sir.
Okay, thank you.
If I may add to that, to this, I know before this meeting, we had tried to extend invitation to radiologists in Nigeria to participate, and I'd also spoken to a number of them personally about getting a critical mass of radiologists interested in interventional radiology, so that we can spread across this specialty and not make it just domicile to Lagos or to distant centers where the average Nigerian will not be able to access. But a lot of questions came up in terms of the willingness of the institutions to train individuals, the physical infrastructure that is required, the process and the protocols, the consumables that Dr. Ninalowo has already mentioned that are actually very expensive and to procure and to sustain. So ultimately, we hope that as people come back from training and we have internal radiologists come together, we could have this specialty spread across the country so that we have multiple options for use, so that somebody in Sokoto who may not be able to get to Lagos on time may have a closer destination to get this treatment. Thank you.
So I'll just tell you something that's peculiar to interventional radiology. So if you look at the direction of interventional radiology in America now, we've nearly completely separated ourselves from diagnostic radiologists. And the reason for that is that surgical specialty now, meaning that, I was just on and my phone was ringing. Can you hear me?
Yeah, we can hear you now.
Can you hear me? Yes?
We can hear you.
Okay. I was just on this call, and the reason I was on my phone is that I have a trauma patient at Evercare in Lagos, so I'm going to have to run there once I look at the CT now with a hepatic laceration and a bleed, right? So my night has been decimated by this call, right? So most people go into radiology because they want to be radiologists. They want to manage life, they want to sit in front of a computer, read, and be done. And so only certain type of people go into IR. And this is what I've been trying to explain to a lot of radiologists. So some radiologists have come to our practice, for example, and they've seen the practice. And after a while, they basically go, this is not for me, right? So we need specific type of people to understand what IR is, right? We now see patients in clinic. We follow patients from A to Z. We don't just do procedures and then abandon patients and give them back to surgeons to manage, right? So, I had the privilege of training in a place where, I did a lot of patient management. And especially to do interventional radiology in an environment such as ours, you have to know what you're doing. And it's not just doing the procedures, it's understanding the things that can go wrong in doing the procedures, right? And making sure that you have the tools to get yourself out of trouble, right? So it's a specialty that's quite peculiar because you are inside a human body, you're not opening people up, and bad things can happen very quickly. And if you don't have those tools, then you can you can do a lot of bad while you're trying to do a lot of good. So it's important that, while we're, bringing everybody into interventional radiology and telling everybody to do it, we're making sure that people that are appropriately trained, they understand what interventional radiology is as far as patient management. And they understand that when things go bad, you need to have the tools to take care of those things, or else we are going to hurt patients, right? I've had people tell me when I've told them to come train with us that our training is 2 years, that why can't it be 6 months or a year? People have actually said that to me. So it's an interesting time in our country, it's an interesting specialty. And I just hope we continue to approach it in the right manner and not just say everybody should go train and start doing it.
Mm. Okay, and just as a follow-up question, is there any benefit in patients or in the trainees having basic training in vascular surgery, or general surgery, or hepatobiliary prior to enlisting in interventional radiology specialty?
So it's interesting. So you asked that question because my first trainee is on this conference. And basically, when we put out an ad for the fellowship for the next trainee to come, one of the criteria was that person spent 3 months in general surgery, before they came to us. And the reason for that is we're busy private practice. I don't really have time to teach somebody basic surgical techniques such as sterile fields, how to hold a needle and all of these little things that you would expect a person to know when they come into a training. But again, there's been a lot of resistance to that, in that people don't want to do that. They just said, we want to come train in IR. We don't want to spend any time in surgery. You're asking us to do things that are kind of ridiculous. So again, until people spend a lot of time in our practice or spend a lot of time in interventional radiology, all they see is fancy procedures being done, and they really don't understand what you have to put in, number one, to get the patient on the table, and then number two, to get the patient safely off the table once you've done a procedure on them. So again, there's still we still have a lot of work to do in Nigeria in exposing the practice. But again, we want to make sure that the right people are coming into the practice and not coming in.
Yeah, well, that's very important. I think rather than rushing people through a program and then ending up with half-baked, like you said, interventional radiology is a very special niche, a specialized niche now that you should be able to, tackle any emergent, situations, and having a fair knowledge of vascular surgery or general surgery, at least that gives you an idea of complications that could go, or things that could go wrong in the process of doing this, and you can anticipate those. So I think it will be important for you guys to actually come together as a group and define what the criteria are for entry criteria for those trainees, so that they can prepare their mind. I mean, 6 months, I think, is pretty generous, but for somebody to want to reduce it to 3 months, I think that's really bordering on dangerous, and again, you have to have the patient load to be able to overcome your learning curve. So if the patients are not forthcoming because of cost, how many can you see? How many can you do being supervised? How many can you do yourself? All these things are important. Yeah.
Absolutely. I mean, but we are making progress, I must say.
That's great.
So I think in the next 10 years, the landscape.
Yeah, it looks like Professor Ogo wants to say something.
Sorry, sir. Just to appreciate the good presentation and your wonderful repertoire. Thank you very much. We'll keep looking for radiologists who want to do the IR fellowship. I think that the 2 years is the appropriate thing, because at the end of the day, these patients are not very healthy, stable patients that we need transhepatic embolization and all that. So I think that let us not rush it because we want to become interventional radiologists. Let us do the right thing, even if it's 2 years, and we know that in 2 years' time, we have a number of people who can do it. I think we can wait for the 2 years. Thank you very much.
Great. Thank you. There are so many other questions, but I'm mindful of the time that it's 9 o'clock now. So
Thank you very much, bro.
the president, what say you? Yeah, it's 9 o'clock, but we haven't addressed all the questions on the chat. And I know Dr. Presenter needs to also dash off to go and save life somewhere.
I think it's safe for us to wrap up the meeting at this time, bearing in mind the fact that we've spent an hour and our speaker also needs to be elsewhere to save a life, like has been mentioned. But again, I'd just like to appreciate everyone who has made this meeting possible, from the executives, the board of trustees, everyone, member of society, and our guests who have attended this meeting. And also want to appreciate most especially our speaker, who has given us a very good overview of the role of interventional radiology in the management of colorectal cancer. If there are no other comments or announcements, I'd like to thank us once again for attending this meeting.